Okay, hi everybody. It's 12 o'clock, so we'll go ahead and get started here in just a minute. So I'm going to open up the chat box. So throughout the presentation, if y'all have any questions or anything like that, feel free to type those in the chat box or in the Q&A. And just so I can make sure that if y'all are listening, if you can hear me, if you could type that in the chat box or let me know, that would be great. Okay, awesome. Okay, cool. So thank y'all so much for joining us today. We're going to be talking about survivors' rights as they pertain to medical advocacy. My name is Leah Tugwell-Poole, and I am NCCASA's Rural Sexual Assault Services Specialist. My role is to support advocates and other partners who are working with rural survivors and being mindful that rural survivors are not only being served by our rural programs, but many of our more urban programs have rural coverage areas. I am available to help folks think through how to support rural survivors in a way that addresses the unique barriers that these survivors face. Joining me today is our staff attorney, Skye David, and I will turn it over to her.
Hi, everyone. Thanks for joining us today. As Leah said, I am Skye David. I am our staff attorney. I support our rape crisis centers across the state and then do direct legal representation for campus survivors in Title IX cases.
Awesome. Also joining us today is Deanna Harrington, NCCASA's Director of Member Services and Technical Assistance, and she's here to field any additional questions that y'all may have. All right, so we're going to start today by going over some general NCCASA information. The North Carolina Coalition Against Sexual Assault is an inclusive statewide alliance working to end sexual violence through education, advocacy, and legislation. You can find more resources and information on our website at nccasa.org. NCCASA as a statewide coalition uses a social justice framework. Therefore, our work is done from a strong intersectional social justice perspective. By centering our work around marginalized communities, everyone is served. And then here's just an overview of the work that we do. So we have our training institute. We support rape crisis centers across the state. We have resource sharing and technical assistance that we can offer. As Skye mentioned, she works on a lot of our legislative agenda and policy change. We do offer language services through the language line. We support colleges and universities, offer prevention education, and also have anti-human trafficking outreach. A note about language that we just want to go over is you'll often see she is the victim and he is the harm doer. While we know that men can be victims and women can be harm doers, evidence shows that 90% of sexual assault victims are women and the majority of harm doers are men. When presenting information about sexual violence, try using they, them pronouns as a means of being more inclusive of all survivors, because we want to be cognizant that victims and harm doers can be gender non-binary. Some things to remember: not all women are survivors, not all men are harm doers. Women can be victims and men can be harm doers. Sorry, men can be victims and women can be harm doers. Another note about the webinar, your video and audio is muted, so we won't be able to see or hear you. If you have any questions during the presentation, please put them in the chat box. We may not answer them right away, but we'll do our best to answer before we move on to the next slide. And there's also a Q&A feature that you can put questions into as well. Either will work, and we'll be looking at that throughout the presentation. All right, so we're going to do an icebreaker just to start off today and make sure everyone's chat box is working and just to kind of get the presentation started since we're not in person. So what is your favorite ice cream flavor? Y'all can type it in the chat box. I think mine is probably like mint chocolate chip. That's always a winner. I see lots of cookies and cream. Chocolate coconut, that sounds delicious. Chocolate therapy, I love that. Lemon pie, I've never had lemon pie ice cream. That sounds good. Awesome. Well, thank y'all for participating. Everyone should try Friendly's Black Raspberry. Okay. Mint chocolate chip and pistachio, like together or two separate flavors? Together would be interesting. Well, thank y'all so much for participating. So we'll go ahead and get started. So during this webinar, we're going to be talking about survivors' rights as it relates to medical advocacy. And we're going to start by going over some of the rights survivors have in the hospital and what the advocate's role is. And then we'll talk about reporting and kit tracking. And then we'll address billing and victims' compensation, and end the discussion today with information on working with survivors that are under 18. This is also making me want ice cream. If there's anything that you have a question on that we don't have the answer to, we'll do our best to find the answer and get back to you as soon as possible. And, you know, throughout the presentation, we really want to hear from y'all about what your experiences are. So if you have an example of something that we're talking about that you want to share, please feel free to do so. All right, so the goals of this webinar are to develop confidence in describing the survivors' reporting options, gain a deeper understanding for rights of survivors under 18, learn more about survivors' right to an advocate, gain skills to use as an advocate to ensure survivors' rights are not violated, and gain confidence discussing the billing aspects of a forensic exam. Another note about language that I'll just start off by saying is that throughout the presentation, I'll primarily use the term forensic exam. I prefer this term because not all folks who choose to get an exam following an assault have experienced rape, and not all survivors want to call the assault that occurred rape. Other terms that are often used are evidence collection kit, rape kit, sexual assault evidence collection kit. As always, match the language and the tone of the survivor. So if you're working with a survivor that says they want to do a rape kit, then by all means, match that language. All right, so the survivor has a right to an advocate, and it's important, and the advocates have an important role to play in ensuring that the survivor's rights are not violated during the process of evidence collection or general follow-up care after an assault has occurred. While there's no written statute stating that the survivor has the right to an advocate, it is best practice for the hospital to call the Rape Crisis Center to have an advocate come to the hospital to be with the survivor. This process should be discussed in the MOU with the hospital, Memorandum of Understanding. If you don't have an MOU or you haven't updated yours in a while, we're going to talk more about those as part of the series, but I'll say here that it's really important to have an MOU with these kinds of protocols to ensure that there aren't any survivors that don't have support. In addition to the right to an advocate, the survivor has the right to an advocate and a nurse that they feel comfortable and safe with. So depending on the survivor's intersecting identities and the circumstances of the assault, they may feel like they want an advocate that has similar identities to them. And, you know, it can be tough, but try not to take this personally. At the end of the day, remember our goal is to support the survivor and reduce as much further harm as possible. Sometimes the survivor may feel that the nurse that's working with them is not understanding or is victim blaming or generally doesn't feel like a safe person to be with. The survivor has the right to feel safe with their healthcare provider, and there's things that you can do as an advocate to help with this. So some of the skills that you can use is to check in with the survivor and read their body language. Does the survivor seem uncomfortable? Are you noticing that the nurse is using minimizing or victim blaming language? While you're in the exam room, some things that you can do are remind the survivor that they can request another nurse if they don't feel comfortable with the one they have. If the nurse is doing something that isn't trauma-informed or is potentially causing the survivor distress, see if you can intervene by saying something like to the survivor saying, do you understand what's about to happen? Do you understand the process? If the survivor says no, you can ask the nurse to explain it further. If the nurse is using victim blaming, minimizing, or otherwise harmful language, ask to speak to the nurse to the side. If the kit has already started, then the nurse may not be allowed to leave the room because of protocols around evidence collection, but you can pull the nurse to the side and you could quietly remind them of what kind of language may be more helpful. One example of this could be if the survivor uses they, them pronouns, you may need to give the nurse a gentle reminder if they're misgendering the survivor. If a nurse is outright denying a survivor their rights, such as telling them they can't decline parts of the kit, remind the nurse that the survivor has the right to decline any part of the kit that they're not comfortable with. And if the nurse gives any pushback to this, it could be the time to request another nurse or talk to the charge nurse that's available. And it's important, of course, to remember to center the survivor at all parts of advocacy. So making sure that you're checking in with the survivor along the way and asking them what they want, but also being kind of aware of what's okay and what's not okay. There's other folks at the hospital that you can talk with if you feel like you're not getting the response from the nurse that you or the survivor is looking for. Some of these people are the charge nurse. So the charge nurse is kind of like the manager of that shift. They hold more authority and might be able to intervene. And they might hold a little bit more knowledge if it's a newer nurse or something like that. The social worker, there may not be a social worker there at the time of the kit, but you can request for the hospital social worker's contact information or for them to call you so that you can discuss the experience, obviously with the survivor's consent. And the survivor may also want to speak to the social worker themselves. The attending physician during the time of the visit, sometimes they're called the attending. They're often kind of like the hospital supervisor during their shift, and their role is to make sure that patients are getting the care they deserve, so they could also potentially intervene if you have a nurse that you feel like isn't doing what they're supposed to be doing. Finally, if you want to make a complaint to the emergency department, you can contact the director of the emergency department. The ED director may not be there during the time you're with the survivor, but you can reach out to them by phone, email, or letter. You can request a meeting or a conversation about the experience. And again, just making sure you get the survivor's consent throughout the process. And you know, the reality, unfortunately, is that in the moment, you may not be able to change that survivor's experience, but you can provide information that may improve services for future survivors, and working with the survivor that's in front of you and helping them understand that, you know, it's not their fault. And if things are, and they're not being treated with that respect from the health team, you know, helping the survivor to understand that it's not because they did anything wrong and you're there to advocate for them. So in addition to the hospital staff, there are members in the community that you could also advocate with the survivor. It may be related to their experience at the hospital, or it may be related to another part of the process. Some of these folks are the victim advocate at the law enforcement agency you're working with, if you are. So that could be an option. Skye at NCCASA could potentially provide you with some support or guidance. If the survivor is a student, you may be able to advocate with the campus Title IX office if applicable, or other support.
Well, I'm not sure what this is asking. Work on the kits faster. So as far as priority of kits, there is a process that the statewide team looks at, And that's a multidisciplinary team, and they look at prioritizing the kits. And I think this kind of goes to the second question of whether we're caught up with our rape kits or are we still behind. We are still behind. We are still testing those 15,000 rape kits that we had backlogged at the beginning of 2018. I will say the state has fully funded the testing of these kits, but as you know, it costs about $700 to test each kit. And as far as time goes, the state crime lab has been testing them as quickly as they can, but that statewide team has been prioritizing the kits, and that's based on a variety of factors.
Hey, Skye, this is Dee. Sorry, go ahead.
No, you go ahead.
I was going to address Karen's question about if the kits are processed faster when there's a name. So the point of anonymous reporting is that those kits are not processed. They sit on the shelf until the survivor says they want it to be processed. So hopefully that answers your question.
Thanks, Deanna. Yeah, I guess that clarifies for me what the question was.
Thank y'all. See. Okay, and Karen said that it answered the question, so great. All right, so still kind of thinking and talking about the kit tracking system. Like Skye said, North Carolina has put together a team of folks specifically dedicated to addressing the backlog of rape kits and is working really hard to make sure that that doesn't happen again. And the kit tracking system, the STEMS system, is one of the ways that they've put in place to try to prevent this. And it gives the survivor, I think one of the biggest things that it did was give the survivor the opportunity to track their kit so that the survivor knows like where their kit is and know what's going on with it. And so whether they report it anonymously or not, the survivor gets a tracking number. And we'll talk more about this, but even though the anonymous kits aren't being tested at the time of anonymous reporting, like Deanna was just saying, if the survivor changes their mind and does want their anonymous kit tested, they still get a number so that they can identify the kit. So the State Crime Lab has put together videos to assist those involved in the forensic exam and investigative process to understand how to use the tracking system. And they made one specifically for survivors to teach them how to use the website. So we're gonna take, it's like a little over 3.5 minutes to watch the video so that when y'all are working with survivors who may have questions about using the website, you'll have a resource to refer to as well. So let me get the video started. Is it working?
No.
Okay. It comes up on my computer, but it's like not coming up in the slides. Okay. Okay, now can you see the video?
Yes.
Okay.
Hi, this short training video will give you a little more information about STEMS. House Bill 945, or General Statute 114-65, as you see here on your screen, here's a link to it, created the North Carolina Sexual Assault Evidence Collection Kit Tracking and Information Management System. We're going to call it STEMS. The North Carolina STEMS program is a web-based application developed to track the status and location of a kit from its creation and throughout its entire lifestyle. Each agency involved with a kit will have users that have access to this system, and these users can log into the agency involved with a kit as it progresses through the investigative process. Users from the kit manufacturers, medical organizations, law enforcement agencies, and crime laboratories will log into STEMS, record the information required, and transfer the kit in order for it to be tracked in real time throughout the process. STEMS will provide transparency to you by providing a real-time access to the location and status of your kit within the system website. In addition, the website will have important resources to assist you, the survivor of a sexual assault. The Department of Justice and the State Crime Lab will monitor and report on the collection and analysis of the evidence in kits across the entire state. Access your kit information. Log into this window, and here where it says serial number, enter the serial number that you were given at the time of collection. It should have been written on the top of your green sheet of resource information. Again, type in the letter and the number. You can drop off the leading zeros or enter them. And you're going to see a pictorial representation of the kit as it's created, as it moves into the medical center. Once it's been collected, it'll move to the law enforcement agency with jurisdiction. The jurisdiction will then transfer it to the laboratory for analysis. And then once it's analyzed by the lab, it'll be returned to the law enforcement agency. Below, you can see each of the steps written out with words and dates as well. But this is just the easiest way to see it. And you'll see a status. As it moves through, the status will change. Once the laboratory has completed analysis, this status will say analyzed by lab. You can check it at any point by typing in that serial number here and see exactly where it is. And one more time, this is the website to get to the STEMS program. So type in this site, that'll open that window, and from here you can enter in your serial number. You have instructions down here, but again, simply typing in the serial number provided to you by your medical facility where your kit was collected will take you straight to your kit, and you'll be able to see it throughout the tracking system.
Okay, let me get the PowerPoint back up just a second.
Our discussion for the COVID-19 concepts, and the discussion is very, very interesting today. We will go over the math plus protocol, and I have actually started calling it a little math plus protocol because there are some modifications that I think we.
And I just want to clarify too that the video talks about kind of basing the assumption that the survivor reported not anonymously, but if the survivor does choose to report anonymously, what the kit will show, the kit tracking will show, is that the kit was picked up and it was taken to the warehouse. So it won't necessarily have all the steps that were shown in that video, but it will just say that it's at the warehouse.
And again, I will note that both the STEM system and or an advocate will be notifying the survivor before their evidence is destroyed, so the survivor can make a decision at that time whether or not they want to report and have the kit tested. This chart is a process chart for the backlogged sexual assault kits. This again comes from the Attorney General's office. The DOJ has been doing some statewide trainings over the last year on what this looks like for law enforcement, and they do feel that they have trained most law enforcement on the proper protocol and process. So hopefully if you were to reach out to your local law enforcement agency, they've had this training by the DOJ, and if they haven't, the DOJ has almost all of these videos online, so you can point your law enforcement to that. This just shows you the steps after the sexual assault kit has been collected and the law enforcement agency comes to the hospital or wherever that collection site was, they have the custody of the kit. They then enter the sexual assault kit into STIMS, and that certifies it into inventory. And then, as I referenced earlier, that multidisciplinary team, which includes advocates, law enforcement, the DA, they review the kits and prioritize the kits. And then they send outsourcing approval requests to the state crime lab. We just don't have the capacity at the state crime lab to test all of the kits that we have in custody at this time. And so the crime lab reviews those requests and they send approval and create the case records. Once that happens, they provide vendor contact information and shipping instructions, and then that law enforcement agency then sends the sexual assault kit to that vendor. And once the vendor receives, they test the kit, return it back to the state crime lab and to the law enforcement agency simultaneously. So what that is, back to the state crime lab, they'll review, they analyze data, upload the profiles into CODIS, and then generate a report to the law enforcement agency, notifying them that it's been uploaded into CODIS. And then we see if there is a CODIS hit. And if there's a CODIS hit to a known individual, they confirm the sample and submit the reporting to law enforcement agency. And then the law enforcement agency submits the standard to the state crime lab. They process that and generate the report. And it is back at the law enforcement agency. So that is for the back. Oh, go ahead. Sorry.
Oh, I was just going to say, it looks like we have another question in the chat box about, with all the steps, is there any chance of these kits getting tampered with? And has there been any cases of tampering with the kits? I don't know that personally. I don't know if Dan or Skye knows.
I don't have any firsthand knowledge of any kits being tampered with. There is, I mean, with any evidence collection, there is always a window where there's cross-contamination, and that could happen. But these sexual assault kits have to be guarded, and I know that that is something that you have to go through training on. I don't know of any personal stories that we've heard of someone thinking that once their kit has been in this process, it's been tampered with. There have been plenty of stories we've heard in North Carolina, however, of just destroying kits over the years, but not, tampering with the evidence as it's moving through the system. I don't know, Deanna, if you want to speak to that as well.
Also have not heard of that, but again, like Scott said, it doesn't mean that it hasn't happened. We just haven't been made aware. And anytime you collect evidence, there's always that window.
Thank you. And then another question that came in is it true that Charlotte tests their own kits rather than using the state crime lab? Is tracking enabled for those kits as well?
That is true. Charlotte does have their own testing, their own lab, and they have tracking as well in Charlotte, yes.
Is it through a different website, or is it still the same process? Do you know?
It's still through the DOJ process.
Okay, awesome. Thank y'all for your questions. Those are good questions. Okay.
Okay, so for the sexual assault kits and billing of those kits, our state statute explicitly allows for free evidence collection kits. And hospitals, medical providers should not be billing survivors for the sexual assault kits and the whole exam itself. This includes not billing their insurance provider, and the RVAP, our Rape Victim Assistance Program, is billed for this exam. And this is the case for attempted or completed sexual assaults. I will say the total for reimbursement is $800, and that is in statute. It qualifies up to what amount can be spent on each service. And so as far as the physician or SANE nurse who takes the kit that has up to $350. The hospital facility fee is up to $250, and then other expenses up to $200 for a total of $800. In the program, RVAP makes a payment directly to the medical facility or professional, and they should not seek reimbursement after 1 year from the date of the program. We should note that if a survivor chooses to remain anonymous, the program is required to verify the chain of custody of the rape kit and confirm receipt by local law enforcement. I also just want to note that we have heard plenty of stories where folks are charged for their rape kits, and we would just encourage you to reach out to us at NCCASA. We can get in touch with the hospital. Oftentimes there is a billing issue. It's just an accounting error. It wasn't coded correctly. Those are the types of things that we hear. Of course, it's incredibly problematic, and there have been some news stories recently about hospitals billing survivors, but it is in state statute that they are not to do so. So there is no real legislative fix for that because it's already in state statute, but we can work with the hospitals on behalf of the victim if they choose to allow us to speak on their behalf. For victims comp, who is eligible for victims comp? Now, I want to, from the outset here, note that this is different than RVAP. It can be confusing for survivors, for advocates, for everyone. So for victims comp, your qualifications are just crime or attempted crime occurred in the state. If the crime occurred or is attempted against a resident of the state while in another state that doesn't have a victims comp program, the victim would be eligible. Again, I'm using victim language because that's what's in statute. The survivor must file an application within 2 years after the date of that conduct that caused the injury or whatever it may be. Economic loss must be incurred within a year of the date of injury. In these cases, economic loss must be incurred if someone is deceased from it. It has to be within 2 years, and the conduct must be reported to law enforcement within 72 hours of its occurrence, unless there is good cause for the delay. I just want to note there, I know that's a hard hurdle for everyone, but it is noted that it has to be reported within 72 hours. So it can make it harder for us to get victims comp money for someone who doesn't report immediately to law enforcement, which is why blind reporting could be really helpful if you have a victim who may not want to participate in the full process. It does also require that the victim fully cooperates with law enforcement and prosecution. The award cannot benefit the offender or the offender's accomplice. And the victim cannot have been participating in a felony at the time, and it can only pay for economic loss. Some restrictions: the program doesn't compensate victims for damaged or stolen property or for pain and suffering. Medical expenses related to the injuries are only eligible for review in that 1 year period following the date. How is the survivor reimbursed? When the claim is approved, payments will be sent directly to medical providers. Out-of-pocket payments made by the victim, like prescriptions, co-pays, will be sent to the victim. Who qualifies, or what qualifies or doesn't? The program does not compensate victims for damage or stolen property, again, or for pain and suffering. So your emotional distress from it would not be included. And medical expenses related are only eligible for review for that 1 year period. But other things that are included include therapy, and that's often something that we hear from folks. That's what they use it for therapy.
So like Skye mentioned before, sometimes because someone entered a code wrong at the hospital, or sometimes personnel, if they're new, they may not know North Carolina's policy on rape kits being free. So if the survivor gets a bill, like Skye said, you should always contact the hospital, but NCCASA would also really want to know about that, just so, like Skye said, we can work with them to ensure that this doesn't become a pattern and continue to happen. And the other thing that I wanted to talk about here is that so sometimes the survivor gets a bill, and if the survivor doesn't want to report or doesn't qualify for victims comp for some other reason, or doesn't want to apply for victims compensation, we still want to make sure that survivors aren't crushed by financial burden because they received medical services. And also, thinking about how not every survivor chooses to get a forensic exam collected, but they would choose to get some other sort of medical support. And so we want to make that as accessible as possible. So we've had questions in the past of what other options are there if, for whatever reason, victims comp isn't an option, or rape victims assistance program isn't an option. And the short answer is there aren't really a lot of other options. And so I think that's where, as advocates and at rape crisis centers, we have to get more creative, and also kind of has us needing to rely again on those community relationships. So there might be some local organizations in your area that have funds set up to help assist victims of crime. I know that some colleges and universities have survivor funds for students who were assaulted. And also, it may be something that your agency can think about starting a fund for is, additional medical expenses. So I just wanted to pose the question of, do y'all know of any organizations in your community that could potentially be supportive in that way?
I also want to note here that if the survivor gets a bill from the hospital, it may be because their bill was above the $800 provided by RVAP. If there were some other injuries, those are not often covered by RVAP. So just be cognizant of that, especially when you're just talking to a survivor, that if they had, a broken bone or some other injury where they needed a CAT scan or something like that, those expenses will be billed to the survivor or their insurance. So please just be cognizant of that.
If there are any places that y'all know of or good relationships you have in your community that helps or has helped in the past with things like this, I'd love to hear about it. And you can drop that in the chat box. Right now, we're going to take a minute to just take a breath, get some water, and after we take a break, we're going to start talking about working with minor survivors. So I wanted to give an opportunity to ask any questions that y'all may have from the first half of the webinar. And again, you can either put those in the chat box or you can put them in the Q&A. I'll just give it another minute or so in case people are typing. Okay, someone asked, can you repeat again the key difference between blind reporting and anonymous reporting? I can start answering, and then if Skye has anything that she wants to add, or Deanna. So I would say the key difference is that anonymous reporting is there's no law enforcement report taken with any information, and it has to be you have to choose to do the anonymous report at the time of evidence collection, whereas with a blind report, it is a police report in some ways, but you can do it whether you decided to get evidence collected or not, and you can do it, you don't have to do it at the time, like immediately following the assault, and you don't have to give any personal identifying information still. And then I would also say that some conversations I've had in the past with some programs have said that their law enforcement agency has given them pushback on blind reporting. And so I think, again, talking to your law enforcement agency and making sure that that's something that they offer, and talking about some of those benefits that we went over before. And then if Deanna and Skye have anything they want to add.
So I think the thing that Skye said that resonated with me is that anonymous reporting is only connected to when you're actually having evidence collected. So it is only connected to going to the hospital and can only be at that specific time, whereas blind reporting, like Leah said, is choosing to go to law enforcement to just provide some basic information that doesn't include identifying stuff. The next question is, with an anonymous reporting kit, is there a limit for you to go ahead with the process? So I'm not quite sure we understand your question, Karen. Can you expand on that a little bit? Is there a time limit with anonymous reporting? So anonymous reporting is connected to the evidence collection process, which every hospital will be different in terms of the number of days. Most community-based hospitals are up to 72 hours. Most of your Department of Defense hospitals are 96 hours because semen can live up to 5 days. So the time limit with the anonymous reporting is the same time limit as when you have, if it sits on the shelf, how long do you have to have it processed? So it sits on the shelf for a year.
And this is Skye again. I just want to note that it has to be kept for at least a year. And it could be kept longer, but the survivor will be notified as to when that evidence will be destroyed.
Good questions. Are there any other questions? In the chat box, someone said, how is the survivor notified if the kit was anonymous? And because the survivor still gets a tracking number, so their name may not be on the kit, but their tracking number will be, and the survivor will have that tracking number as well.
So the other piece, with anonymous reporting, and I've worked with other advocates who've struggled with understanding, like, anonymous to us means no name, whereas the kit in itself on the paperwork has a name, is that once it gets to the actual facility is when the name comes off, and it's only connected to, like what Leah said, the tracking number. So the nurse, yes, is writing the name down, but it's still anonymous in the sense that the only people who know are the nurse and the person who enters that information into the system at the less storage facility.
And if you have any questions about anonymous reporting, or want to talk about it further, I know Deanna put in our member services team's email addresses in the chat box. So So feel free to reach out to any one of us to ask any further questions, or if you need further clarification on that, because it can be really confusing. If there are any other questions, keep them coming, but we'll go ahead and switch gears here to start talking about working with minor survivors. And Skye will start us off with that.
So I'm just going to cover the relevant law. I know a lot of agencies have different policies on this, but the law in North Carolina is that if the patient is under the age of 18, a parent or guardian must give written consent for medical care. But we do have a law that says a minor may give consent for services for the prevention, diagnosis, and treatment of STIs, pregnancy, abuse of controlled substances or alcohol, and emotional disturbance. I just want to also note that there was a Senate, this says House Bill, but it was Senate Bill 199 last year that passed. And I referenced it earlier during this webinar that it does state that if there is an anonymous report, for example, where you have a minor reporting to a hospital, then that person who receives the incident of sexual misconduct or sexual violence does have an obligation to report to law enforcement. So it does make that a little bit trickier with an anonymous report at a hospital with a minor. That is something that we are actively working to change the law about. We have been working with SANE nurses across the state to make sure that they will be covered so that we won't continue to run into that problem. However, it also included the statute of limitations for minors. Similar to an adult sexual assault, there is no statute of limitation for felonies, but for misdemeanors, it is 10 years from the minor's 18th birthday, so age 28. And if they chose to bring a civil action, that is also a 10-year statute of limitations. Some other things to consider. Please work to help hospital staff understand the sensitivity of these cases. Parents and guardians often accompany minors when they're seeking care after a sexual assault. We just encourage medical professionals to be sensitive when questioning minors about consensual activity and the history of sexual assault in the presence of others. And this is something you could work with the staff in your hospitals on, especially with MOUs. Prior to beginning the exam, ask any person who is accompanying the patient to leave the room briefly. So if you're there as an advocate, you can kind of initiate that conversation. We also do want to note that minor survivors cannot anonymously report regardless of who the harm doer is. I should have said that when I was talking about Senate Bill 199. It doesn't matter if it is a parent, guardian, or someone else. There's no exception for that unless the minor reports to a rape crisis center. You do have that privilege, but as far as the hospital goes for medical purposes, they do not hold that privilege currently.
And so I'm going to talk more about the advocacy piece of working with minor survivors. So I know most of us, unless you have a certain setup at your agency where you also maybe have a CAC attached or a family justice center or something like that, a lot of us probably work primarily with adults and adult survivors. So when we do have a teen survivor, we may not be sure what to do or what we even can do. I know when I was at a local program, a lot of questions were like, are we allowed to serve those who are under 18? And kind of what's the agency policy on this? So that's where I would start. If you are seeing a lot of survivors that are under 18, or you aren't really sure what your agency's policy on this, I would definitely ask. And if there isn't one, it might be something to explore. And of course, there's a lot of things that you may want to consider, like your liability insurance, and kind of like if you have certain staff that have certain types of licensure as far as like providing services go. So those are a few things that you may want to consider. And then there may be other things depending on your community and the setup of your agency and the capacity of your agency. But I think it would definitely be a good place to start. It's just kind of exploring that policy. And then also, you know, talking with your child advocacy center. So if you're seeing a lot of survivors that are minors, it may be helpful to reach out to your CAC to ask them for assistance or support. And it can be really helpful to have an ongoing relationship with your CAC. And every CAC has a different screening process. So some won't see children past menses or puberty. And it's helpful to know their policy on this, because if they're not able to serve the minor, somebody needs to. So that might be where you kind of start thinking about your policies. And so usually a multidisciplinary team determines who can be a referral partner for a child advocacy center, and rape crisis centers are not always on that list. So that's also something that I would encourage you to kind of find out, is if you are a referral partner. And if you're not, it may be helpful to set up a meeting with your CAC to talk with them about the benefits and challenges of being added to that list, and come to a decision that best supports the survivors in your community. And if you're responding to a hospital call where there is youth involved, you may want to contact the CAC beforehand just for general information about responding. You don't have to give personal identifying information. And you can also ask if it would be okay for you to follow up with someone there about any questions or concerns that pop up. If you're unable to do this before you see the survivor, you might just want to give them a follow-up call to check in and make sure you've taken all the steps that you need to take. The goal is to make sure that the survivor and their family has everything they need, because like Skye said, usually caregivers and guardians are involved when there's a minor sexual assault. So just kind of making sure that the family has support as well. You can reach out to children's advocacy centers in North Carolina at the link on the screen. And the second link will tell you which areas there are CACs in North Carolina. So you can check to see if there's one in your area or one close by, and who serves your area. And I saw a question, but it may have already been answered. So the other thing that I want to talk about is that there are differences in service delivery when it comes to serving survivors that are under 18. Most of the time, I would say, in my experience, when I was working with a survivor that was a minor, they did not want to be there. They didn't know why they were there. Their parents told them that they needed to come, and they were just there because they were told that they had to be. And so I think that it's really important to build rapport with our minor survivors, because most of them are probably, even more so than adults, not going to want to talk about what happened, and they probably won't know what they need right now to heal or what they want the next step to be, especially if the person who caused them harm was like a peer. We know that, especially for young adults, it can be really confusing to have that happen with a peer, and there may be even more pressure to just not talk about it. So building rapport, I think, is really important, and not pushing the survivor to have to tell us anything, and letting them kind of do that on their own, but talking with them about, you know, why your agency is there, what you can do, how you can support them, what their options are, what to expect, like what's normal following an assault to feel, things like that. And then obviously working with minors, you're often also working with their parents. So helping parents understand the importance of survivor choice and autonomy, I think, is another huge part of working with minors as advocates. Is a lot of the parents will come in and they will be just as confused about what to do as the survivor may be, and they think, okay, I'm going to bring them to this rape crisis center and they're going to tell me what to do and we'll go from there. And, you know, that's not our job to tell people what to do. It's just to kind of talk to them about options. So when you're working with their caregivers, what I think is really helpful is, even though sometimes what we see the caregiver is doing, we might see it as like furthering harm or being re-traumatizing. So educating their caregiver on, you know, again, what's normal after experiencing assault, what's normal to feel, what are some normal behaviors, how to support the survivor's choice to either talk about it or not talk about it, and talking with parents about those kinds of things. And then also remembering that we do support secondary survivors. And so a lot of the parents may need support themselves to talk through what happened. And we know that the pervasiveness of sexual violence, and so a lot of parents may be survivors themselves. And so having a child that was assaulted could be really triggering for them. It could be bringing up a lot of feelings. It could be, you know, bringing up a lot within them. So I think it's really important that we don't just look at it as maybe we would with adults that are like, maybe like single adults, where they might be the only person that we're talking with. We have to kind of consider the other pieces of the family and the impact on them as well. And so supporting secondary survivors, I think, is definitely more common in these situations. So keeping in mind that even if the parent doesn't share with you that they're also a survivor, you know, knowing that's a possibility and treating them as you would the survivor. And again, just continuing to help the parents understand why it's so important to just kind of take the lead of the child. So those are just some initial things that I would think about when working with minor survivors. And that's pretty much all I have as far as that goes today. But if y'all have any additional questions about working with minors, please feel free to ask them. Or if you have any questions about the presentation at all, we're going to take some time for Q&A. Okay, so, but the list listed under the new bill is more expansive. Oh, this must have been part of a previous question. And includes some acts not included under 7B 301. What does that mean?
Sure, Skye again. So the question was about child abuse and mandatory reporting. We're all mandatory reporters in North Carolina for abuse, neglect, dependency, and maltreatment. And so I think the question here is about, wouldn't we already be a mandatory reporter under that for minors? And rape crisis centers and agents of rape crisis centers are specifically privileged under this new law. And it does include other offenses, such as rapes, sexual offenses, quite a laundry list, including acts between minors. And so it would be an expansion of that abuse, neglect, dependency, maltreatment. So if a minor just comes to a rape crisis center and reports that they were sexually violated by a peer, that counselor or advocate who took that information would not be required to make that report. In the same way they would have to make a 7B 301 report, abuse, neglect, dependency, maltreatment, and 7B 301 only affects those caretaker, custodian, of the child. So if it's a parent or a caretaker. So this is an expansion of that. They are not the same statute, they are parallel.
Awesome. Are there any other questions that y'all have about anything that we talked about today, or things that you need more clarification on?
So I just put this in the Q&A under the question Juliana had around the Senate Bill 199 and all those pieces. And so I wanted to remind folks that if you are a member of NCCASA, you have access to our membership database, which includes all of our resources, toolkits, and manuals that we have developed over the years. And one of them is a toolkit specifically for Senate Bill 199 and includes the flow charts that Skye mentioned. We also have the previous webinar that Skye did around Senate Bill 199 on our YouTube channel. So folks can also check it out there.
Thank you, Deanna. I will give it a couple more minutes for questions, but I'll go ahead and say thank y'all so much for coming. I hope this was helpful. And I can, well, I'll repost our email addresses in the chat so that y'all can have them. I know that some of the stuff around survivors' rights can be a little confusing. So if you have any further questions, or after the webinar you're thinking like, oh, I wish I had asked that, please don't hesitate to email us. And Skye's email, Skye's email is also on this screen. So I know that she's happy to answer any questions. And then there are 2 more webinars as part of the medical advocacy series. One will be talking about supporting survivors across their healing journey when it comes to medical access, and the other one will be about MOUs. So please join us if you can. As mentioned before, this will be on our YouTube page and in Coalition Manager, and I think we can send the slides out as well, so we can do that. And I hope everyone has a great weekend, and if you need anything, let us know.
Hey, Leah, do we want to just let folks know when about the certificate process?
Yeah, so everyone, if I'm speaking correctly, and if I get it wrong, I will email you and let you know. But our certificate process is that at the end of the month, you will get a certificate for all of the NCCASA webinars that you attended. So you're not going to get one necessarily immediately after this webinar, but at the end of the month, all the ones that you attended, you'll get a certificate for.
Perfect. Thank you.
Yeah, absolutely. All right, everybody. Have a good day.